again on stage. Well, that was great. I mean, they were really high-quality startups. Some were a little bit more than just early stage. I was really impressed by their solutions and the fact they've had so much traction. These are, of course, the SMEs we're describing now, and earlier we had the startups. So we'll also announce the winners at some stage, and then we'll feed back to you as to how they got on in their raising of funds for the next level. And we look forward to hearing the success stories that come out of it. So now we're on to our next speaker here, along the same kind of lines and themes of digital health and innovation. And it's a pleasure to welcome our next speaker. I think it's a company called Docobo, who are doing a lot of work in transforming care and the community, but also working very much in Liverpool. Rob Halhead is the Chief Operating Officer of that company, and hopefully he'll share his story and the work they're doing, particularly in Liverpool. Thank you, Rob. You've got a... Rob, it should be...
Click a button?
Yeah.
Click a button. Let's see what happens. Great. Okay, so what I'm going to do is share with you the story of Liverpool so far. Liverpool's a leader in the field of telehealth. It's been doing this stuff since about 2012. And it's been driven largely by a couple of organisations. One is Liverpool CCG, the commissioners, people who pay and drive what happens, and Merseycare. And Merseycare is England's largest mental health trust, and also does a great deal of community service, community provider, as we tend to call them in the UK. So these are the three main partners in this with ourselves. We're just the digital enabler of change. And the partnership extends much further. It goes out to the hospitals as well. So I could mention Aintree, the Royal, or Luft as it's all called now, Clatterbridge for its oncology services, who we've been working with, and Aintree as well. That's a specialist respiratory program in motor neuron disease. So large partnership at play, and Liverpool's a great place because it has a unique culture within the UK, and it lends itself well to collaboration. Partnering is a bit of an abused term, but I can vouch for the level of collaboration that we enjoy here in this city. So what I'm going to do is move on to describe what we've been doing and what we're going to do. This whole business has moved on from, pushing. My partner in crime is Adrian Flowerday, the founder of Docobo, and he's been evangelizing this stuff for the last 20 years. I've only been doing it for 12 or 13. But COVID arrived last year, and since last year, it's no longer a case of if we're going to adopt digital, it's yes, we are. All the boundaries fell away, all the barriers, rather, fell away. So now it's just a case of, okay, what are we going to do with it? So a little story first about the reasons why. Now, if we start on the left-hand side, we've got rising demand. I don't think anybody in this audience would thank me for explaining the reasons why demand is increasing so much. We know about long-term conditions and aging and all of that, and comorbidities. And then we've got strategy. Well, the strategy in England's NHS is the 10-year plan. And the plan, of course, is to move as much care to the home as possible. So out of hospital care, hospitals are expensive, we know that. And our resources are limited. And as one guy who leads this program in Liverpool said, quite pithy statement, he said, well, we haven't got enough doctors and we haven't got enough nurses, so we're going to invest in digital. What else would you do? So then, we're doing some firefighting, aren't we now? There's nothing to be done. We have a backlog, thanks to COVID. And the least we can do is try and limit the effects of the backlog. The hospitals would not thank us if there are patients occupying beds who really don't need to be there. And so can we make this whole business preventative? Can we move to proactive care rather than be so reactive as we have been in the past? Now, the backwash to this slide, if you can make it out, is Well, we need to move the goalposts, and there's a picture of Liverpool football team moving the goalposts. If anybody watches football at all, you might know that Liverpool last night didn't move the goalposts, they moved the goalkeeper. Enough. If you don't follow Liverpool, I'll apologise now. Right. So first off, can we identify the patients that we need to intervene with? Because this is all about efficiency and productivity. Can we get the maximum out of those precious trained clinicians in the front line, be they GPs, consultants, nurses, whatever? So we have an intelligence system which operates, some people talk about population health, again, that's another abused term. The system that we have goes from population right down to individual patient level. I'll give you a little insight to that in a moment. So we can identify the people, having analysed all that data, and all of that data is GP data, it's hospital data, it's from community care, it's from mental health trust, and it's from social care. So it's integrated data for an integrated care future. Right, we can identify the people. Who's costing me the most? Who's got 3 or more long-term conditions? All those comorbid guys. Who's in and out of hospital? Why? Are those patients receiving the care that they should? We can analyse this stuff till the cows come home. So we pick out the people for an intervention. The intervention may be electronic with our telehealth. It may be anything at all. Then we can create the cohorts having selected and identified the people who most need the help. And then we can evaluate as we go. Now, I spared you the marketing diagram, which has got the usual circle on it. I'll appreciate your thanks for that. But this business is awfully complex, and what we've got here is a circular process of identifying the people, intervening, measuring the intervention, go again, adjust if we don't get it right. This is just a little insight to the kind of data that you can get from the system. Now, if you can't make it out at the back there, we've pseudonymized it, of course, and the system manages pseudonymization. The only people who get to see patient identifiable data are those involved in direct patient care. Now, down the left-hand side there, if you can make it out, we've got the ages of the people, male, female, and then as you work this way, there's various data in there about their risk score, whether it's going up and down. And these guys have got quite a lot of comorbidities. This is taken from real data. We're talking about fairly elderly people with 8, 9, 10 different conditions. And as you work your way down that, then the clinicians, it's a clinical choice about who to intervene with what, and when. And this helps us identify the right people. We can create the cohorts, and then we can load up the data across to the telehealth system. Now, I've mentioned Liverpool, CCG, and Merseycare before. So on the right-hand side there, we've got a very simple representation of how telehealth works. So it's patients entering data by a variety of means, because we have to watch out for digital exclusion and equality of care, which is an obligation, strong obligation on the NHS. This being a taxpayer-funded system. So they enter the data, we're taking observations, it's daily, it's twice a day, it's whatever the clinicians decide. And on the left-hand side there, we've got a little bit about productivity. So the nurses in the hub at Liverpool, this is Merseycare's operation. Pre-COVID, they were managing by about 1 nurse to 300 patients. During COVID, we took the system from about 1,800, 2,000 users up to 5,500, something like that. And this is for the patients who were shielding from COVID largely. And then we had COVID oximetry at home to prevent silent hypoxia, etc., etc. Now, during that period, we had 1 nurse to 400. Actually, it was more like 1 to 450 to 500. And that's because the measurements, the observations for COVID were quite simple. And what are we measuring? We're measuring the vital signs, and we're measuring the symptoms as well. This gives you a little insight to what they're looking at. I won't go into all the depths of the system. It's an enterprise-grade system. The top half, it's the physiological things like blood pressure, oxygen sats, and so on. And the lower half, where the colour bars are, well, that's the symptomatic questions being answered, and behind it's multi-choice, multi-answer. And behind each of the answer is a colour code. So if there's a symptom like how breathless are you feeling, or how anxious are you feeling, any of those sorts of questions, then it's green, amber, red. Alerts, there are parameters set for individual patients. I could go into massive detail. I haven't got the time. You could just manage by the alerts for each individual patient because the parameters can be set to the individual. Your blood pressure and mine is different, so the system caters for that. So with these observations, what can we observe? Well, we've got the vital signs. I've mentioned that. We can take people's ECG. With the ECG, then we can measure a lot of the metrics like QT. We're measuring QT interval, and that's for a mental health trust, where they want to understand what the QT interval is before they prescribe and administer psychotropic drugs. There's an enormous amount of things you can do here. Now, breathing rate is something that we introduced through the COVID virtual ward program for the Royal Hospital as well. We can measure virtually anything. So somebody just prior to me was talking about a UTI sensor or blood test. Great, bring it on. Symptoms, we can have any kind of symptom. There are 200 message types in a library on the system, but the nurses and the clinicians can create their own. For the motor neurone disease program, we created, I don't know, about 20-odd questions in a completely new set just for the poor people who are suffering from that horrible disease. Scoring, lots of scoring, whether it's in our population analysis system or whether it's on the telehealth system. And these are just examples. E-frailty. News 2 is the National Early Warning Score in the UK. That's used throughout the hospitals, and we can use it at home as well for discharging patients, and we can speak the same language. Whether the patient is in primary or secondary care, it doesn't matter. MUST is about malnutrition. FRAT, FES1, TINETI, these are all full scoring systems. HADS, GAD 7, PHQ9, those are mental health ones. And we've got CHADS, VASC, and there are plenty of others to go around. If you want to do social isolation, you'll be talking about a scoring system called Luban. So we can do all of that on the system, and we can do survey questions as well, like friends and family, PAM scoring, which is patient activation, you name it. So there's an awful lot of data being made available by this technology. And the important thing is that this is clinically led. We're just one small part, we're the enabler, we're just a cog in this great big wheel of health and social care. Now, since the beginnings of this, we've moved to a point now post-COVID. Yes, the barriers have gone. So Adrian and I are not out there pushing this idea anymore and evangelizing the benefits of digital health. No, it's now becoming a pull, which is great, because when we're talking to our clinical colleagues, we listen like hell, and now, right now, we're doing an awful lot of listening because people are picking up on all of this and what does it mean. So I'm talking about how we transform out of hospital care, and this gives you some of the hints. So on that left-hand box there are the clinical priorities right now. So care homes, they got a bit of a bad deal out of COVID. They need some help. And our resources are seriously stretched. Serious mental illness, or SMI, again affected by COVID, and the physical health checks for people with mental health has reduced as a consequence. Now, we have that equality of care, and sadly, people with mental health conditions have a lower life expectancy than those without, and that needs evening up a bit. So they need physical health checks, and the digital can help them do that. Respiratory and cardiovascular diseases have been high priorities since I can remember, and they certainly are now. Wouldn't it be great if we could reduce stroke to the point of elimination? It'd be fantastic, that, and I suppose what I'm doing is giving you a hint about what might be coming. The symptoms of COVID, long COVID, will be around with us for quite some time. And for me as a non-clinician, it's a bit disappointing to see the ratio, the number of people who are still affected by it. Supported discharge and virtual wards I mentioned a little bit earlier. Since doing it in and during COVID, that's a concept that's not going away. So I think probably here in Liverpool, the next one to go that way will be with cardiovascular conditions, and that's working with the hospitals. So this hub where all of this data is being monitored, all these observations coming in, becomes a center of intelligence, and it can instigate proactive care, which is where we really need to get to. So they're looking at the observations. We can deliver education and motivational stuff to patients. So we have a library of video clips in Liverpool. They have a library of about 50 short videos to educate the patient so that they can become more capable in self-management. The folks on the call from the hub also strike a relationship with people. You will see a quote on my last slide from one of the patients who reacted to that. So when the nurses and the HCAs are calling people and giving them a bit of help, hi, how are you doing? So this is the reality of proactive care. You can see the observation, you can phone the patient, see how they're doing. If you see some signs of deterioration or if an alert goes off and something really is wrong, then there's a phone call. And if the blood pressure fell like a stone that morning, well, we'll take the measurement again. And if that's still the case, an intervention is organized. And the hub integrates with everybody else. So there are a set of protocols and operating procedures so that GPs are notified, they're told about what's happening. And of course, note, the GP is not directly involved because this is daily, it's constant, it's observing those patients. So what it's doing is reducing unplanned care, but where there is unplanned care, then it's organizing an early intervention. And of course, the data is there to be shared. We haven't got there yet, but one of the aspirations I'd like to see is that a paramedic going to see, say, an elderly person out of hours in the early hours of the morning who's having trouble breathing. Wouldn't it be helpful if the paramedic could just log in and see that clinical screen that I showed you a few moments ago? The GPs can see that, by the way, and so can the community nurses. About time paramedics could see it, I think. So we can detect early deterioration, we can deal with that. I say we, that's the clinicians, because this is not our business, it's the clinical one. And the virtual wards, great. We can get people out of hospital, we can reduce readmission rates, and we can reduce length of stay. So bringing it all together, and this is what's happening in Liverpool. So I started off by talking about increasing capacity, because that's the fundamental problem for the NHS. This demand is just going on and on and on. And we've reached the limit of supply, if you think of the economics. So what digital is doing is bringing some virtual capacity. It improves patient outcomes. If we can prevent a COPD exacerbation, which is happening on a regular basis, then that's preventing destruction of some lung tissue. It's flattening out that decline in that patient's health and helping them to live longer and with a better quality of life. We're introducing new processes. So one area for new process attention very soon will be some of the district nurses going out there to do injections and doing wound care. And this is just adding to the capacity of the technology to help improve the life of the clinicians and take some load off them. Prevention for patients, well, if we could reduce that stroke, that would be great, wouldn't it? There are far too many strokes. It can be a fatal experience, and it's definitely very damaging, and not just for the patient either, but for their family and their carers. So prevention, we want to do more of that. As the communication, education, and coaching, which I mentioned a few moments ago, reducing load on the clinicians, we're going to use the tools so you can establish a video call with the patient if you want to. You can communicate with them by text, by anything. You can even do video message or audio. The opportunities here to really make an impact are virtually limitless. We can reduce the admissions. Interoperability is worth dwelling on, because with a single system doing all of this, collecting all of this data, then we know at Dockerbill that we are not the single panacea to all things digital in healthcare. We are not. We'd like to think that we're a decent cog in a very big wheel, enabling lots of things to happen, and we have to interoperate. We have to share that data, and what we're collecting is rich. It's laden with rich information about patients, and we do want to share it. As long as we're not committing commercial suicide, we will integrate with anybody. And we've done that with the GP system, EMIS. We've done it with things like Fitbit, for instance. So if there are any more sensors out there that are helpful, we'll integrate, we'll connect. So I started off by saying we want to shift the goalposts. And you can read that statement at the top, which comes from a patient, a grateful patient, who Merseycare interviewed. What I will emphasize is those last two sentences, and this gives us an insight to, is this digital stuff any good? Because care is human to human. I, as a patient, at times, I just want to see my GP, I want to see a consultant to get some advice, and person-to-person communication is far richer than being too remote. However, the digital can give you that daily observation data. You get the phone call from the nurse. It has an important part to play. And this is a perfect example of a patient reacting to that and saying, I know it sounds strange, but it was like having them in the room with you at your side. And she's referring to the nurses at the hub. I never felt I was on my own. Fantastic. So we have to move the goalposts. We are moving them. And all I'd say at the end is, well, they've gone. Where did they go? Thank you for listening. I hope that's been helpful.
Thank you so much, Rob, for coming and speaking and talking about experiences, which has been amazing. And you're right, I think, chronic diseases, manage them better at home, in the community, preventing hospital admissions is kind of what you're thinking about, and which I think is right. I mean, chronic disease, as I said earlier, we pay about 60% of all the NHS funding into chronic disease. So that's kind of what makes sense from your perspective, yeah?
Exactly.
Yeah. So these are the kind of solutions, of course, we've been discussing all day, how to make a difference using either digital therapeutic, technology, and innovation. Rob, thank you so much for joining us.
My pleasure. Thank you.
Okay, so we're moving on to our last session. You're probably exhausted, all of you, and hopefully you're still here with us virtually at the live event on the show. So look, we've covered a lot of work today. It's been an amazing day in terms of the content, the quality of the speakers, and I guess the way it's been showcased through live channels, also our virtual platform. Hopefully you enjoyed the virtual platform. I hope it's worked well for you at home. I know it's a difficult time and a different time to come to conferences. Our last session is from McKinsey, who are our knowledge partner in Giant, and they've been supporting us for the past few years. I'm really glad they're on board to help us navigate the healthcare system with experience in healthcare. McKinsey, as you know, write regular reports around healthcare, around future technologies, the landscape of the healthcare systems around the world. It's worth seeing what they write regularly, because they really are very much in tune with the changes taking place. So this is going to be a pre-recorded video with the panel.